Good day, everyone. My name is Hadiza Salili and I work with Clinton Hill Access Initiative. I will be presenting on how CHAI integrated responsive feedback to engage religious and traditional leaders as champions of gender justice and sexual and reproductive health and rights. The Sexual and Reproductive Health Program was a 4-year program funded by Global Affairs Canada from 2018 to 2022. The goal of the program is to enhance the reproductive health and rights of women reproductive age and empower them to make informed choices about their reproductive health. One of the strategies implemented by the program to achieve this is widely known as Religious and Traditional Leader Strategy, which is RTL, which was focused on conducting orientation sessions for religious and traditional leaders on gender justice and SRHR. Rolling out the RTL engagement approach incorporated the 5 steps of the COP process during the different stages of planning, implementation, monitoring, and evaluation. Religious and traditional leaders are gatekeepers of culture and religion and have influence on their male and female followers in a culturally sensitive and conservative settings such as Kano, Katsina, and Kaduna, where the project was implemented. Therefore, it was well recognized from inception by the project team, including the funder, that it will require a process of continuous learning, iteration, and collaboration to implement an effective and sustainable project. In 2019, CHAI collaborated with the Gender, Adolescent, School Health and Elderly Care Department of the Federal Ministry of Health and gender experts at local and international level to develop a new approach for orienting religious and traditional leaders on gender justice and SRMNH. During the implementation stage, the project sought to understand how effective this approach was in creating the desired change. The project team intended to understand which methodologies are effective, relevant, acceptable, and which ones are otherwise. A critical knowledge gap is whether the training is sufficient to cause a positive shift in the attitude of religious and traditional leaders on SRH. Another key question that was unanswered at this stage is if the approach led to appreciable increase in knowledge, attitude, and practice of community leaders on gender responsive and adolescent friendly SRH services. It was well it was important to fill these important gaps to support the iteration process, ensure gender responsivity, and achieving the project outcomes. The project also sought to understand if the revision of the theory of change was necessary, especially around activities that need to be conducted. To address the knowledge gap in developing a robust approach for orientation of religious and traditional leaders, the project team conducted a 3-step pilot. The 3-step pilot included during the engagement of master trainers, engagement of state trainers, and the final pilot testing was conducted in 3 sample LGAs per state. 1 urban, 1 rural, and 1 semi-urban LGA were selected in each of the 3 program states. The overall aim of the pilot was to gather evidence that will help to ensure effectiveness, cultural suitability, and acceptance of the orientation approach. Methodologies employed to this evidence-gathering mission included qualitative and quantitative data collection methods. Design questionnaires and assessment forms were complemented with verbal feedback received by the participants, who intended to provide additional context. The team engaged in post-activity review and team reflection sessions daily and after the conclusion of each pilot stage to analyze data, share and compare notes and observations. The iterations are carried out immediately before the next stage of the pilot. Both operational and programmatic recommendations were received from the participants. A common recommendation is to incorporate religious perspective of child spacing into the sensitization guide. Participants also suggested that lactational amenorrhea should serve as an entry point to the discussions around short and long-acting contraceptive methods. The use of the term family planning was strongly discouraged and to use child spacing instead in all forms of communication. An exercise in the Module 2 of the sensitization, known as fathers by accident or by choice, was also suggested to be removed. The team also realized from the assessment results and observation that there is need to conduct additional activities that will lead to positive shift in attitude and behavior, especially around adolescent health. Operational recommendations made by the participants included reviewing the 1 day to additional days, and also to exclude Fridays and limiting the orientation sessions to a maximum of 6 hours due to the engagement of religious and traditional leaders in other community activities. The project team implemented all recommendations received from the participants except for increasing the number of training days. These recommendations included the updating of the theory of change. Initially, review meetings with RTOs were planned to discuss progress and develop actions on conducting community sensitizations. The review meetings was subsequently expanded to become the joint SRM managed review meeting, where the participants of community change agents engaged by the program, including traditional birth attendants, healthcare workers, patent proprietary medicine vendors, family lab and HIV education teachers, emergency transport scheme drivers, and youth champions. The joint review meeting helped the religious and traditional leaders to reflect, relate, and understand the challenges that women face in their communities from the experiences of change agents. It also facilitated collaborative action between RTLs and other community change agents. This meeting also incorporated sessions such as the story of Aminata, a story that allowed the religious and traditional leaders to reflect and empathize with women and girls and identify their roles in SRMNH promotion. Resource constraint was a key challenge in increasing the number of days of the orientation. Example of a quote from the Quran that was included is, "His mother bears him with hardship, and bearing of him and the winning of him is 30 months." This is from Quran chapter 46, verse 15. Conclusively, responsive feedback helped to successfully work with religious and traditional leaders to act as agent and also champions in their communities. Below is the feedback depicted by coach received from the different traditional leaders that have even led to self-practicing healthy timing and spacing of pregnancy. Quantitative analysis also showed improvement in knowledge, attitude, and practice. Between 2019 to 2022, the percentage of religious and traditional leaders who viewed family planning as a positive practice increased by 29 percent points, while the knowledge of family planning also increased by 44 percent points. CHAI also took some steps to institutionalize responsive feedback within the organization and also for the government. CHAI trained government staff from the State Primary Healthcare Management Board on how to use participatory approaches and responsive feedback to improve community engagement approaches. Additionally, a demand generation strategy toolkit was developed for the social mobilization officers to use, especially in male engagement activities. At organizational level, responsive feedback was adopted during the TBA review meeting, which has now been adopted by the government to conduct its own TBA review meeting. This is the end of our presentation. Thank you for listening.